Hello, Trinity Tigers. Welcome to the Learning Together live webinar series as part of lifelong learning activities and initiatives presented by the Trinity University Alumni Relations and Development Departments. I am Robert Blystone, Professor Emeritus of Biology. Trinity's Office of Alumni Relations has invited me to moderate this webinar. It is my distinct pleasure to introduce the webinar panelists. Dr. David Crockett, Professor of Political Science, Trinity University. Dr. Rebecca Michelle Carey, class of 2012, postdoctoral scholar at Kellogg School of Management at Northwestern University.
Hello.
And Mr. Victor Rodriguez, class of 2014, Masters of Public Health and now MD candidate 2021, College of Medicine, Texas A&M University.
Hello all.
Please know that you may ask questions as you follow this webinar by using the Q&A tab on your screen. Our panelists will respond to your questions to the extent that time permits. First, I will provide a historical context to this discussion by providing a brief review of the 1918 influenza pandemic that is estimated to have killed 50 million citizens of the world in less than 2 years. George Santayana made the statement that many people now know: those who cannot remember the past are condemned to repeat it. Let's look at the memory of H1N1 influenza, also known as the Spanish influenza of 1918. Next slide, please. The chronology of World War I is interesting in that through the actions of World War I, a pandemic was created. And at the same time, the pandemic modified certain events of World War I. Of greatest interest to us is that on November 1918, armistice was declared and World War I was drawn to an end insofar as combat was concerned. Next slide, please. The picture that you see is one of the most famous of the recorded images of the pandemic of 1918. Because of congressional action, images, descriptions, elements, history of the pandemic were suppressed because it might affect what was going on with the war. With that in mind, the first US patient, 0, was at Camp Funston in Kansas, and he was a cook by the name of Albert Gitchell. He reported the sick call on March 11th, 1918, and our story begins. 3 weeks later, 1,100 troops at Fort Riley, Kansas, were hospitalized, as you can see in their convalescent area in the picture on the right. Next, please. There were 3 waves of H1N1 influenza. The first wave occurred between March to August of 1918. It is suggested that 3/4 of the French army, 1/2 of the British army, developed this first wave influenza. The first wave influenza was not so virulent. Most people were ill for 3 days and then back on the job at that time. The transmission of the virus was done primarily through troop movements. The second wave occurred between August and December of 1918. It was extremely virulent, extremely deadly, and its virulence was associated with what we now call a cytokine storm. That storm would overpower the immune system and cause death. This began in Plymouth, England in August of 1918, and then moved to Brest, France, Boston, Massachusetts, South Africa, and it was done again through troop movements. The third wave of influenza occurred January to August 1919. This had started in Australia. It was very virulent, it was deadly, but it was not transmitted well because peace had occurred, and as a result, there were limited troop movements. Next slide, please. The US combated the flu primarily through military sources, and leading this effort was Dr. Rupert Blue, the United States Surgeon General. In some ways, he reminds us today of Dr. Anthony Fauci. There were a number of vaccines developed. They were focused on what was called Viper's bacillus. Today we know it as Haemophilus influenzae. Multiple vaccines were tried on different combinations of bacteria and all failed for a very simple reason. Influenza is caused by a virus and not a bacteria. Plasma was also used from recovered patients, but the technology of the time didn't allow this to work well, and thus it failed. Aspirin had just gone off of patent, and as a result, we had a cheap chemical that was able to deal with body pain and temperature. The problem was that a little bit of a good thing was used at 40 grams per day, and toxicity of aspirin begins with 4 grams. Many people died because of overdosing with aspirin. Ultimately, we're left with non-pharmaceutical interventions, NPIs. Next slide, please. We all know about NPIs because of our COVID experiences. Avoid the indoors, be around fresh air, close theaters, operas, and bars, close schools and churches and similar, avoid crowds, burials and funerals, move to the graveside, not in churches. Simple things like no spitting, which was a big deal in 1918, covered coughs, wear face masks, and of course, sanitation and personal hygiene. We have a picture here of a Army care facility that was found in Massachusetts in 1918. Next slide, please. Here we have a bunch of soldiers at a movie in France, and as you can see, they're all wearing face masks. In the right image, you can see soldiers marching in Seattle in 1918, and they're all wearing face masks. Face masks have been shown to be an effective device for controlling influenza, also COVID-19. Next slide, please. Here's a group of Red Cross workers that are making masks in Seattle in 1918. We have in the right image 2 Boston nurses shown in their different states. Their masks were made primarily out of gauze. Next slide, please. So everybody should wear masks. And I even found how to put masks on alligators and caterpillars. Next slide, please. So the sign of the times. We have people who were wearing masks. And in some places, if you didn't wear your mask, you could be put in jail. In other places, you could receive a citation and had to pay a $5 fine. Also, public service announcements, PSAs, as seen in the cartoon on the right, indicated that you were supposed to cover your face and etc. Just common sense things that we now understand oh so well. Next slide, please. So to summarize, 500 million people had H1N1, the Spanish influenza virus, nearly 1/3 of the world's population in 1918-19. Approximately 50 million people died, about 2% of the world's population. 675,000 Americans died, or about 0.7% of the US population. Ladies and gentlemen, I'm now turning to our first panelist, Professor David Crockett, who will discuss political polarization in the country as it has developed over the past 40 years and how it relates to our current divisions. Dr. Crockett, please.
All right, thank you, Dr. Blystone, and welcome everybody. I'm going to make use of my discipline of political science to provide one possible explanation for why we're so divided in the midst of what is clearly a natural disaster. Now, under most normal circumstances, Americans tend to unite when facing crises, whether it's an economic crisis like the Great Depression, or a national security crisis like 9/11, or a natural disaster like a hurricane. But we are clearly not united when it comes to the proper response to COVID-19, which is an event that involves scientific facts that you would think we'd all agree on, both as to what happened and how to deal with it. And I think one of the principal reasons why we do not have general consensus in this crisis is simple, and it has to do with the central story that impacts all of American politics right now, and that story is political polarization. So what I'm going to do is tell you this really complicated story as swiftly as possible, and I think hopefully it will explain why division seems to mark our response to this pandemic. So what is polarization? Let's first make sure we know what polarization is not. Polarization is not partisanship. Partisanship is the feeling of attachment or belonging one has for a political party. And the fact is that most Americans have some sort of partisan attachment, or what we in political science call partisan identification. You're a Republican or a Democrat or a third party. But people can be very partisan without being very polarized. In fact, for many years, it was not uncommon to find liberal, moderate, and conservative Republicans and liberal, moderate, and conservative Democrats. In fact, the most liberal Republicans in the 50s, 60s, and 70s were more liberal than many moderate and conservative Democrats, and vice versa for conservative Democrats. Polarization, by contrast, refers to the existence of substantial differences in political perspectives, typically along a single ideological dimension, like liberals versus conservatives. Now, some measure of polarization is inevitable. The only way to avoid it is if everyone agreed on everything, which would give us unanimity, not polarization, and that seems to be impossible. Or if our differences were distributed in a completely random fashion, such that it would be impossible to establish any stable alliances in politics, that would be perfect pluralism, but it also seems to be pretty unlikely. So the question really isn't whether there is any polarization, but whether there is something peculiar about it today. And the answer to that is yes. Let's show us the first party polarization chart, please. So this is a classic graph depicting polarization over the years. The higher the line on the graph, the more polarized our politics. And we have seen increasing polarization at the elite level in the political class over the past 40 years. Everyone agrees on that. But many scholars also argue that we see some level of popular polarization as well. We know that over the past few decades, the Republican Party has become more uniformly and monolithically conservative, while the Democratic Party has become more uniformly and monolithically liberal. So liberal Republicans became Democrats, and conservative Democrats became Republicans. And that has given us a more polarized politics. Now, where'd that come from? And this is going to be a really fast story. For 100 years after the Civil War, the South was lockstep part of the Democratic Party, and that was true during much of the New Deal era. That began to change in the 1960s as liberal African Americans moved from the GOP to the Democrats, and conservative Southerners began to drift to the GOP. The disruption of the 60s, think of Vietnam, urban riots, the sexual revolution, and a whole bunch of other social and cultural changes exacerbated those divisions. Just think of what you see on the TV show All in the Family, for those old enough to have seen that. And this is not solely a political phenomenon. We see this in religion as well. One transformation that took place at this time was a cultural realignment. At one time in our history, our main divisions in the nation were between Catholics, Protestants, and Jews. And what has happened since the 60s is a realignment, so that the divide is now between Orthodox Catholics, Protestants, and Jews versus progressive Catholics, Protestants, and Jews. So those who are Orthodox tend to adhere to an external transcendent authority that is unchanging, while those who are progressive tend to adapt their symbols of faith to the changing assumptions of contemporary life. So things got so bad that in the 1970s, when you think of Watergate and Carter's presidency, voters actually began to de-align from political parties. Many of them became nominal independents. But the election and presidency of Ronald Reagan clarified the ideological differences between the parties, and voters began to sort themselves into their natural partisan homes. And Newt Gingrich really capped this off in 1994 when Republicans took control of Congress for the first time in 40 years. So you could say is that what began embryonically in the 1960s was birthed in the 1980s in this phenomenon I mentioned earlier, where the conservatives all became Republicans and liberals became Democrats. Now, why does that movement cause polarization? Well, there's a lot of debate in political science about the details of this story. Did the political elites polarize first and drag the population with them, or did the population polarize and the political elites reacted because political elites like to win elections? Either way, the results have been pretty clear. More and more, our presidential nominations have been marked by appeals to the base, because if you can't win the support of the anchor faction in your party, you're not going to win the nomination. More members of Congress have become uniformly stacked on one side of the ideological spectrum. Go ahead and show the next slide, please. So if you look at this, back in the 50s, 60s, and 70s, you could find liberal, moderate, and conservative Republicans and liberal, moderate, and conservative Democrats, and they overlapped each other in the middle. Now, the most liberal Republican is more conservative than the most conservative Democrat, and there is simply no overlap between the two parties anymore. Increasingly these days, strong conservative candidates challenge moderate Republicans for the nomination, and they win. And we are also seeing strong progressive candidates challenge moderate Democrats for their nomination, and they win. And that means there are fewer and fewer moderates in either party in Congress. And that affects everything from who gets leadership positions to the abuse of the filibuster as a regular legislative tool in the Senate. When people accuse Paul Ryan of being a rhino, which is Republican in name only, you know you've traveled pretty far to the extreme. It also means that every issue becomes a matter of life or death. Back in the 50s, 60s, and 70s, it was not unusual for party leaders to forge cross-partisan or bipartisan coalitions on issues, and those coalitions would change from issue to issue. Compromise was possible and things got done. But since the early 80s and 90s, diverse policy arenas like economic welfare and foreign affairs and civil rights and cultural values have all collapsed into a single issue alignment. So if you tell me what you think about one area like gun control or tax policy, I've got pretty good odds I can tell you what you think about many other areas as well. And it's all liberals versus conservatives, and that has now become channeled through the two parties, Republicans and Democrats. All the issues have become nationalized, and all of our measurements of polarization indicate that we are as polarized today as we have been since just after the Civil War. So let me close by describing why this impacts our reaction to the pandemic. Keep in mind the basic facts of my story I'm telling. Our political elites have, since the 1980s, become completely sorted into natural partisan homes, and these parties have become almost uniformly liberal or conservative. And voters often perceive things in this way as well. This affects how we perceive events, such as our evaluation of the economy and our evaluation of the health of the nation. Republicans toward the end of the Obama presidency thought everything was horrible, and Democrats thought things were pretty good. Then Trump got elected and the opinions reversed long before Trump had actually done anything. So political scientists know that our perceptions of things are influenced by our partisan perspective. And since our partisan perspective is increasingly a uniform and monolithic ideological perspective as well, these different interpretations ratchet up in intensity over time. George W. Bush was the most polarizing president in American history until Obama. and then Obama was the most polarizing president in history until Trump. So if our evaluation of facts, of the economy, of the prosecution of a war is all influenced by this ideological lens, why would we think that our evaluation of the handling of a pandemic would be any different? As the parties grow further and further apart on basic ideology, on how they even see the world, it becomes more and more difficult to come to agreement about the description of facts and the methods to respond to crises. The room for compromise seems to disappear, and rather than see each other as simply political opponents, we now see each other as enemies who are dangerous to the republic. So in 2016, some conservatives referred to the presidential election as the Flight 93 election, which is a 9/11 reference, where conservatives thought they had to storm the cabin or the republic would fall. And it's pretty clear that the Democrats in 2020 see things the same way about the prospect of a Trump re-election. And watching the Republican National Convention last night, Republicans think the same thing about a Biden election. And if that's how we see our political opponents, the result is a massive distrust of the other side and a suspicion that everything they propose is motivated by partisan gain and that will destroy the country. So it's not the pandemic that is dividing us in this way. It's the divisions and polarization that have been working their way through our political system and the voting population for decades that have made it that much more difficult for us to respond to this issue. And I'm not exempting or excusing any specific political leader or party from responsibility, but it's our politics that have led us very gradually over time to this point, and that's why we're divided. And that's my story.
Thank you, David, for the insights. May I remind you that there is a Q&A part of your screen where you might wish to ask questions or make comments. Our next panelist is Dr. Rebecca Carey. She will share her recent research on the experience of COVID-19 across gender, race, and social class. Dr. Carey.
Thank you, Dr. Blystone. There we go. I'm really thankful for the opportunity to be here today and to discuss the question of why are we divided. Addressing the COVID-19 pandemic will require a united effort. It will require that people work together collectively to achieve our shared goals. And for that reason, it is so incredibly important to understand the sources of division around COVID-19. I propose that understanding why we are divided in part requires understanding that people have fundamentally different experiences of this pandemic, and that these experiences are critical to informing and supporting people's attitudes and beliefs about the pandemic. So today, I will specifically be talking about how COVID-19 has been experienced differently across social class, gender, and race. There's already been a fair amount of coverage in the news and media about how the COVID-19 pandemic is experienced differently across these groups. Most of what's come out has focused on health and financial or economic disparities. For example, although Black and Latinx individuals make up only 31% of the US population, they make up 51% of diagnosed COVID-19 cases and 40% of deaths due to COVID-19. Furthermore, shutdowns, stay-at-home orders, and quarantines from the pandemic have caused massive job loss and an economic recession in the US. But this job loss hasn't been experienced equally. Women are more likely than men to have lost their jobs, people of color more likely than white individuals, and those with a high school level of education have been more likely than those with a college level of education to have lost their jobs. As I noted, these differences in health and economic outcomes have been some of the more researched and discussed disparities, and they highlight fundamental differences in how the pandemic has been experienced across social class, gender, and race. However, in addition to these disparities, there have also been marked disparities in psychosocial outcomes. Psychosocial refers to the influence of social factors on individual psychologies, that is, how people think and behave in the world. This concept is a recognition that who we are and the things that we do are intimately connected to the people and social structures around us. In my research, I've examined how COVID-19 has impacted social fabrics. What's a social fabric? It's the totality of our connections to each other. It's our relationships, our interactions, our views of others, and our views of society. It includes not only close relationships, but also social support, social norms, trust in others, and a myriad of other social factors that contribute to a functioning society. A few months ago, in May, I got together with several other psychologists across the country, and we decided to tackle this question of how COVID-19 impacts social fabrics. Overall, we discovered that COVID-19's impact on these social structures varied markedly across race, social class, and gender. I'll share just a few of these results with you now to give you an idea of what we found. I'll start with close relationships. We have an intuitive understanding that COVID-19 presents a challenge to our close relationships. I particularly like the phrasing that was used in an Atlantic article where Helena Fitzgerald wrote, "Love is the opposite of hygiene." That means that doing what's best to stop a pandemic may not be the same thing as doing what's best to maintain your relationships and care for the people that you love. Although this is seen as a universal challenge, we find disparities in how COVID-19 impacts close relationships. For example, we found that with lower income, people experience more loneliness and disconnection from close others. We asked our participants how lonely they had felt over the previous month, and we found that the people with the least amount of income generally reported the most loneliness, and with increased income, people reported less loneliness. On the flip side, we also asked people whether the pandemic had actually brought them closer to their family and loved ones, which is one of the cases of that tragedy and struggle can bring people closer together. And we saw the opposite trend here, where more income actually predicted people finding a type of silver lining in the pandemic and that it brought them closer to their family and loved ones. We found that women experienced more strain in their relationships due to the pandemic than men. For example, more women reported that compared to before the pandemic, they had experienced more arguments and fights at home, and that during this time, they had reacted to stress by yelling and fighting with others more than men had. We found that race shaped how much people felt the COVID-19 pandemic was a threat to their family members. Now, across race, we found that people generally agreed on how threatening the pandemic was to themselves, but we found differences here in terms of what they felt about their family members. Compared to white individuals, we found that Black, Latinx, and Native participants perceived that the pandemic was a greater threat to their family's physical health, to their family's mental health, and to their family's financial well-being. Now, these three findings all pertain to close relationships, but we also found disparities in more broad, less personal social factors. For example, we found that people with lower income reported less access to social support. Now, this is especially concerning because in the absence of economic resources, social resources, such as social support, are critical for surviving and thriving in the world. Nevertheless, we found that people who are most in need of social support, that is, those with the fewest economic resources, were the least likely to have access to it. So here's just two examples that I'd like to show you. And one is that people with less income, people reported that it would be harder for them to find someone to help them if they were sick. And also they said that they would have a harder time finding someone who could give them a place to stay during an emergency. And I chose these two examples because I think that they're especially pertinent to how people might handle and address issues during the coronavirus pandemic. We found that people's educational attainment was linked to social norms and what they perceived others were doing in their community. Overall, we found that people with less education reported living in communities where people were less likely to engage in protective behaviors against COVID-19. For example, individuals with a high school level of education were more likely to say that people in their community did not maintain 6 feet of distance from others. And they were also more likely to say that people did not wear protective gear, such as masks, in public. Lastly, we found that race shaped how much trust people placed in others. And what we found was that generally, Black, Latinx, and Native participants experienced less trust in experts and authority figures who are likely to be the people communicating important information on staying safe during the pandemic. Now, perhaps as no surprise, these individuals, Black, Latinx, and Native participants, reported less trust in police and law enforcement. But far more surprising, they also reported less trust in scientists and researchers, and less trust in healthcare workers, such as nurses and doctors. So this has been a brief summary of some of our findings. And overall, these results demonstrate that how people experience COVID-19, and in particular, how COVID-19 impacts their social world, depends in part on their social class, their gender, and their race. And if I could provide one takeaway from this research, it's that although we have one country, we have many pandemics. Understanding people's experiences of pandemics then, understanding which pandemic they're experiencing will be critical and important to helping us understand why we are so divided. Thank you.
Thank you, Rebecca, for sharing your research. Our final panelist this evening is Mr. Victor Rodriguez. He will offer his perspectives particularly on the Latino community's health based on his work in the Rio Grande Valley area. Mr. Rodriguez.
Hello all, and thank you to all the presenters for their insights on the topic and the invitation to the opportunity to talk with you guys tonight. So as we dig deeper into the conversation, oh, I lost my screen here, sorry. So as we dig deeper into the conversation, my talk will look closer into the lens of how COVID has impacted a specific group here in our own state. It kind of borrows some of the ideas that Dr. Carey mentioned previously in health disparities in communities, forms of division, and how they've impacted the communities down in the Rio Grande Valley the last couple of days. Though the disparities have been present for a while and they've been affected in many ways, COVID definitely has magnified the situation in the area. Let's see. All right, so although I attend Texas A&M, somewhere in the center there, I rotate in Houston for medical school, but my passion and my training for my master's program always brings me back down south to the population where I hope to serve. I was fortunate enough to do a rotation down there a couple weeks ago, which also happened to be around the peak time COVID down in the valley, and it still kind of is. And I got to also experience the compounding effects of a hurricane. I continue to try to get informed with my friends down there that are healthcare practitioners, and I was kind of excited to see that there was a text thread amongst physicians down there, kind of all helping each other and bringing knowledge on how to protect the people. But as you can see, the Rio Grande Valley is a small little section of Texas made of 3 counties. So for those that don't know, the Rio Grande Valley is located in South Texas, comprised of 3 counties, Hidalgo, Cameron, and Star. The population size, I kind of wrote down numbers for you guys from the US Census. The population size is about 67% of Bexar County, which is where San Antonio lies, and it makes up about 5% of the Texas population. And the reason why I bring these numbers kind of into consideration is because we'll see later on how, even though they represent this specific population amount, they've been significantly impacted by COVID. So as we've heard in the news and from medical professionals, COVID has impacted older populations, and although the population is very similar to kind of the rest of Texas, it doesn't discriminate against the young people. The area is predominantly Hispanic, being around 92%. And I point these two out because these are, the smaller portion also here has very little access to internet, and then graduation rates are lower. Kind of how Dr. Carey had pointed, I bring these into light because they're factors that kind of present in access to health information and health literacy that can impact kind of the course for some of these patients that we see. Another significant issue is the uninsurance rate in the area is very disproportionate to the state and the country. It's about 1 in every 3 in Hidalgo County. So that's just like one of the counties, but it's pretty similar amongst all 3 counties, 20% in Texas and then 10% nationally. And then to add on, the poverty levels are also significantly high in this area. One of the main things that I did in the border during my master's program was working on diabetes prevention. And so I just bring these numbers up here because, as we've seen in the news, these are comorbidities that have impacted a lot of COVID patients in the hospital course and kind of add on to, you know, the disease outcome. So the reason why we see this is because there's so many social determinants of health to consider. Some of it previously discussed, and some of them I'll touch in a little bit. So some of the COVID data that I thought was like really interesting when I was down there, and I kind of updated data from this Sunday, it shows that Rio Grande, if you remember, is 5% of the total Texas population. However, they've seen 8% of the Texas COVID cases. To make it worse, about 15% of the total deaths in the state come from the Rio Grande Valley. I was telling a friend about this and they were saying, oh, that's just a fraction. But to me, it's like, that's for you to be 5% of the population, but seeing 15%, that's not just a small fraction to me. So that's why it's for me, it's like a kind of a passion thing to go down there and work when I can. So what's going on down there? That, like, why are we seeing these divisions? So one of the biggest things that always kind of frustrates me is seeing that there are no public hospitals. That just makes access to healthcare a lot harder for some of the patients. It's only private hospitals down in the 3 counties. The hospital ICUs are getting extremely packed to the point where people are being to die to get admitted. So people are literally waiting in ambulances, waiting for somebody to die for the next person to come in. Freezers are also packed to kind of keep up with the increased death rates in the area. Other things that I saw while I was down there is people are afraid to seek medical care, some of them which needed. For example, I had a patient, diabetic on dialysis, who didn't want to go get his dialysis treatment. And it's kind of scary if you don't, because you put yourself at risk of death. And end-stage renal disease is another major kind of prevalent issue down on the border. Other flip side of that, there's also been people that have been pushed away to seek care because they fear of getting their patients infected. One example is from a friend. Their family member needed a blood transfusion because they were hemorrhaging, but the hospital was like, hey, like, you know, what's your current hemoglobin level? Okay, you know, you have indications for it, but, you know, not right now. And so they were pushed until, like, to the point where they, like, emergently had to give them a transfusion in the end. But it is those kinds of scary things. And then during this time, on July, I think it was 26, they got hit with Hurricane Hannah. So at that time, I was just like, oh my gosh, what's going to happen? And so that area is highly propense to getting flooded. And I'll talk about a little bit about colonias in a bit, but high propensity of flooding, and it just affects the access to getting into the hospitals. Luckily, during the time, a lot of the hospitals ran on backup generators. And so the hospitals really didn't see the effects. So the patients, I think, were safe. But still, there were reports of across the border, Reynosa, literally the couple miles down south, their hospitals are, like, significantly flooded. There were videos going on about doctors waist deep in water. So that was kind of sad to see at the time. So why is the Valley getting hit disproportionately? Again, it goes to the divide. A lot of the topics that Dr. Carey had mentioned. COVID has allowed to amplify, or at least make it more apparent to me on the medical side, of the health disparities in the underserved areas, like the Valley. I already had mentioned some of them early on, but other considerations for that we can take care of are, in social determinants of health. For one is access to health care. So we saw earlier that there was a lack of insurance. One in every 3rd person is uninsured. All private hospitals make it just expensive for patients to seek care, and, you know, delaying some of these treatments for these patients just doesn't lead to a good picture. Another thing that was very prominent when I was down there pre-COVID were the colonias. And what colonias are unincorporated, substandard housing developments that lack a lot of the basic city infrastructure. So for example, you don't have paved roads, you don't have sidewalks, you don't have electricity, you don't have water, sewage. So if you add a lot of these factors, you know, it just makes it harder for people to get around. Moreover, there's also kind of barriers to where city lines are drawn. So sometimes, like, you can call for police, you can call for an ambulance, and there's kind of like this uncertainty of, like, oh, which area is supposed to reply to a specific area. So, like, say you're in between McAllen and Weslaco, and you're in a colina down there, sometimes you don't know where you're going to get your help from, because the ambiguity in lines there. Another thing that we saw earlier was the lack of education. So my organization, the Latino Medical Student Association, we noticed that there's a large prevalence of misinformation spreading in communities such as the Valley, as well as lack of Spanish language material for people. So it just makes it harder for people to be aware of what's actually going on, or kind of dismantle some of the disinformation that goes out in the public. And lastly, the compounding effects of comorbidities have impacted the hospitalization course of some of these patients. As I mentioned, a lot of these patients have diabetes 1 in every 3. A large portion of this population is obese or overweight. So access to healthcare just, has definitely impacted a lot of the course of these people and why we see a lot of this divide. And because I didn't want to end the conversation here, because these are just like points that I saw and why we see the division down in the Valley, I didn't want to end in such a negative vibe, so I did want to bring in some good news. So what I really enjoyed seeing down in the Valley is it also has brought people together. So one example is kind of the school districts. There's a lot of, as I mentioned, there was a lack of access to internet. So I was really excited to hear is that some of the school districts have pushed for increasing access to internet by putting routers in buses and providing free lunches in those boxes. They would go into colonias and, provide that access to these children. And another one that my friend texted me today is that Mission, which is a city in Hidalgo County, had its first successful extubation today. So good news. But yeah, thank you all.
Thank you, Victor, for reviewing your public health work. Now it's time for audience questions. If you've not done so already, please submit your questions to the Q&A tab. I will now read some of the many submitted questions so that our panelists can consider them accordingly. I have one for Dr. Carey. Why wouldn't age be a much better survey pool than race, considering COVID-19 disproportionately affects older people in morbidity?
That's a great question. I think that without a doubt, there's a lot of things we could look at with age. I focus on, again, psychosocial outcomes, and I think that's absolutely worth considering and thinking how a person's age could also affect very much like their social structures and their relationships as well. I would say that I focus on these factors because it's less clear and obvious why people would be affected in these ways. And so it's important, I think, for research to shine a light on these groups, because when we say that people at an older age are at risk of COVID-19, I think people understand that. When you say that people who are, as like Mr. Rodriguez was describing, people of certain ethnicities or races are more vulnerable, or people of different genders are more vulnerable, it's less obvious why that's the case. But I agree, I think it would be interesting to look at how age might also interact with some of the things I look at.
Thank you. Professor Crockett, this person thanks you and says, do you see responses to national disasters and crises becoming increasingly polarized over time, as is the case for political polarization intensifies, or based on the nature of the crisis itself? For example, the country seemed to rally together for a time following 9/11. That did not seem to occur in response to COVID-19.
Yeah, it's an interesting question. Of course, 9/11 was, shockingly enough, almost 20 years ago, which is half the distance back to when polarization really started kicking in. So I think that makes a difference. And it may be that the nature of the disaster or the nature of the crisis impacts things when you have an external attack versus an unseen, insidious, perhaps an enemy that we haven't seen in 100 years. So I don't know if, I haven't done a systematic study of crises to see if that matters, but I do think that political leadership can make a difference. But if that leadership is lacking, or if other forces come into play, once things begin to move along a certain direction, if the parties become separated and rigidified in a certain perspective, it becomes more difficult then to pull back from that. So I think it might make a difference that on 9/11, for example, there was an attack. We all saw it on one day. We knew what the threat was, although it didn't take long for polarization to infect that too. Whereas here, this unseen thing has to cross an ocean. People are saying stuff, and of course the president basically said a miracle would make it all go away. So I don't think it has to be that way, but it's perhaps depressing that it does that even with a crisis, because you think a crisis would unite us, and more often than not, it does not, it seems, these days.
Thank you. I have a question for Mr. Rodriguez. What percentage of the 8% cases in the Rio Grande Valley are due to illegal aliens entering the state? Are ambulances being deployed for this?
So that's a hard question for me to answer, because I was getting my data from the Hidalgo County Health Department, the Texas Health Department, and the Johns Hopkins kind of national. And the reason why I also say that is because as a physician, we're not supposed to be asking those questions. We don't ask our patients about their citizenship status, because it's actually, you shouldn't. I don't know. That's how we practice. You usually don't ask your patient about their immigration status. We're trying to build rapport with them, and so kind of creating that barrier with them, you know, it doesn't lead to good outcomes. But I can't tell you for sure how many of those 8% were or weren't.
Thank you. This one I think I'll just throw out to see who wants to go after it. Did the general public fail to read the cliff notes on infections? Or did we fail to name this virus with a name like STD or UTI to inspire people to wake up and wear a mask? Branding, I guess, is maybe what this question's about.
I'll just, I think, great question. Maybe if we called it breathing transmitted disease or something, people would take it more serious to wear masks. But I think that I would urge people to not think of it as a failing, that they may not engage in the same behavior, or like what we would consider the like right behavior. And to instead think a lot about like the context, whether it's about the political context they're in or the cultural context that they're in or their experiences, and trying to understand why they make the decisions they do. If only for the reason that if you approach a conversation thinking that the other person is just wrong and has made a failing in some way, there's going to be very little communication to be had.
Thank you. This question is directed towards Dr. Crockett. Do you think politically we will ever become less polarized?
Yeah, I do think so. Nothing stays the same in politics. And if you look at my first chart, there are these waves of polarization. It's interesting, when political scientists first started doing survey research, it was in the 40s and 50s. And the sense was that we're a pluralistic nation and people agree, there's a lot of consensus. And that was assumed in political science to be the norm. And it looks now like maybe that's unusual, but you still see this roller coaster, it's a very long roller coaster oscillation. So I have to think that this cannot go on like this forever. There's like a rubber band, and at some point it's going to snap. And I suspect it'll be some kind of a crisis or trigger event that will cause that. Maybe it's this pandemic. We'll see how we interpret the results on November 3rd. But it will snap back at some point, and we'll begin a new cycle, I suspect.
Thank you. This one starts out, Victor, how has the pandemic affected your medical school training?
Mine, not as significantly as the lower level. So I think A&M kind of has a pretty cool system where we start our clerkships earlier. So I just finished a month delayed from what I was supposed to be, but they did a lot of good backup, kind of switching some things to online. But at least at A&M, I didn't feel a significant impact. The only thing that we see an impact is in clinic, where a lot of whoever has gone to the doctor now, like we've switched a lot over to telehealth, which in some cases it's hard. I did have a patient where we couldn't tell if she was having a heart attack or not, depending on like how she was describing her situation on the phone. So we told her to come in. It wasn't a heart attack, but it's still those kinds of things that like it kind of impacts you. Like, oh man, should they come in? Should they not? Because do you want to risk them being out in public and getting infected versus not?
Thank you. Here again is a question that several of you might want to look at. What role does the influence of journalism play in polarization? Journalism seems to be driven by sensationalism now rather than reporting.
I think journalism is a factor. I do not think it's the driving factor, but the technology does matter because what happens now is you have such a fracturing of the media that it's very, very easy for us as voters to cherry pick the news we want to watch or listen to or read. And that means you can screen out alternative voices, whereas you go back 40 or 50 years ago, you got 3 networks and PBS and that's it. Everyone watched Walter Cronkite. But now you can select which outlets you want to consume, and we tend to oftentimes select the ones that reinforce our views. So that would seem to put a lot of power to the media, but I would point out that people who do a lot of political consumption of news have already made up their minds, and people who don't are probably not going to be paying attention to politics anyway. So I tend to have a somewhat tempered view where I don't think journalism is the sky is falling. I think it tends to be a reinforcing factor more than the primary motivator in this area.
And then along with journalism, it's like, I know we did a webinar with our organization with Dr. Shapiro, where we were trying to create a Spanish language, medical disinformation kind of little talk. But definitely like the media, the way at least it plays is kind of, especially like with celebrities. There was a celebrity in Mexico that was telling people, it's like, hey, you should be using this one thing. And obviously influential people can have an impact. And so what I was actually surprised and excited about is that the Univision was talking about like, oh, this other star was fighting them, that saying that, that was the wrong thing to do, which was correct. Like whatever star had come out saying that they should be using this treatment was like very wrong, but stuff like that happens.
Thank you. This one is directed to both Dr. Carey and Dr. Crockett. Any polls about attitudes towards science, scientific evidence, and how that has changed over the last decade?
I don't know the polls well enough to know whether we have evidence for attitudes towards science changing. I do think it's true that polarization prompts people to be selectively suspicious or selectively blind to empirical facts, and that's problematic.
Okay.
I don't know what the polling data suggests.
Dr. Carey, any polls about attitudes towards science, scientific evidence, and how that has changed over the last decade?
Well, unfortunately, my answer will not be satisfying because there definitely are polls about this and there's a lot of research about this. I'm not familiar with it though. I would say that probably we'll see different trends if you look at what's happened in the past 100 years as opposed to maybe what's happened in the past 20, 30 years, the kind of time span in which Dr. Crockett was talking about political polarization increasing. So that's one thing to think about, but I'm not sure, I'm not familiar with the literature.
Okay. This is I like this question, and it's very short, and I think we can all run under a bush. Not that bush, a different bush, okay. Where are the moderate people? I don't know how to go after that.
It's fascinating because everyone I talk to believes that they're moderate.
Okay.
Yeah, they're out there, but if the selection you're given through the selection process tends to push toward either extreme, the moderates don't necessarily have much of a voice then. So, if the nomination process tends to privilege people from faction and they're the ones who are active in the nomination process, then you end up with choices that don't necessarily appeal to moderates. And I do think there's still a lot of them out there. But these are the teams as they have evolved over the last 40 years. And moderates lose in Congress. I mean, you have, let's just take one example. As Susan Collins from Maine quite possibly will lose her effort at re-election, and she's probably the most moderate Republican, and that will make the Republican Party more conservative because she will be gone. And I know that Alexandria Ocasio-Cortez and someone else in New York defeated a sitting representative, making that seat more progressive. So to a certain extent, it feeds on itself.
This is a question for Mr. Rodriguez. If we had a Medicare for all healthcare system, would the US response to COVID have been better?
I think response and access to care are like different things to me. Definitely, I would think it would help patients kind of get access to healthcare and hopefully seek treatment earlier. But response, I don't think has anything to do with Medicare. It's how we govern ourselves or we're being governed to do things. But yeah, it's my short answer.
Okay, thank you. I'm at the point to where I'm supposed to provide a summary, and I'm really not sure how to do that at the moment. We are a divided nation in this regard. I worry sometimes whether the division has more to do with a sense of personality than it does with ideas and idealism. And that tends to bother me. I also want to make a comment that as I have looked through the people who have submitted questions, I am humbled by the fact that I have seen names of people that I haven't talked about in 20 years. And I thank you for your questions. And I can't really come to a summary. I just know that, yes, we're divided. I think all three panelists have explored with us elements of where we're going. And I would like to say in closing then, please guard your health, peace, and go Tigers.